Welcome, everyone. You will see to the right of the screen a poll is open. Please let us know your relationship to the FTD movement disorders. The FTD movement disorders bring their own set of unique issues when it comes to diagnosis and care. I have the pleasure today to be joined by Dr. Nikolaus McFarland and Janet Edmunson to provide an overview of the disease process and care needs. Dr. McFarland is the Associate Professor of Neurology in the Movement Disorders Division at the University of Florida College of Medicine. He holds the Wright-Fall-Simmons Professorship in PSP, Atypical Parkinson's. He is a member of the Norman Fixel Institute for Neurological Diseases and the Center for Translational Research in Neurodegenerative Disease, which aims to bring bench research closer to the bedside. Janet Edmunson is a motivational speaker, writer, and health promotion professional who is dedicated to using her life experiences and inner values to support the growth and self-esteem of the people her life touches. In 2006, she published Finding Meaning with Charles, Caregiving with Love Through a Degenerative Disease, an account of her and her late husband's journey with corticobasal degeneration. We hope to have time after their presentations to allow for Q&A. Please post your questions in the Q&A box as the session goes on. Dr. McFarland, thank you for joining us.
Thank you so much for inviting me. It's really a pleasure to be part of this AFTD conference today, and I'm pleased to give this talk on these disorders today. I'm going to share my slides here. Everybody. Great. All right, so the goal today is to understand these FTD movement disorders and to get a sense of the practical approaches to care. So what I'm going to do today is basically talk to you about the diseases, particularly the movement disorder diseases. Just before I start, I have some disclosures here on this slide. Really, there's nothing that's relevant to this talk specifically, but just to let you know. The goals today really are to talk initially about Parkinsonism and some of the atypical syndromes, how we kind of diagnose them, and then I'm going to really kind of rapidly move into what we call the tau disorders or the tauopathies. And I'd like to discuss really what's called progressive supranuclear palsy, PSP, and corticobasal syndromes. So the objectives here really would like you guys to learn about the clinical features of both of these disorders and the spectrum that goes along with them, some of the basic pathology and the overlap, and lastly, to discuss a little bit about the treatment options and what's coming up next. So Parkinsonism, this is a diagnosis of a lot of patients here, and I'm going to just briefly tell you, this is more of a descriptive term of a constellation of symptoms. I often tell my students, residents, that I use an acronym called TRAP that really just talks about the key features, which are a resting tremor, rigidity or stiffness, slow movement, which we call bradykinesia, and that is most severe, we call lack of movement or akinesia, and then postural instability. You need to have at least rigidity or a tremor in your disease. And of course, all of these syndromes have slowed movement over there. Really, we call hypokinetic movements, okay, disorders. So of these, the most common, of course, is Parkinson's disease. There's 1 million patients alone in the United States. However, about 10 to 15% of what we see doesn't really fit typical Parkinson's, and we call them atypical Parkinson's disorders. And I am going to allude here that more and more we're discussing disorders based on some of the clinical and pathological features that we are learning and gaining a lot more knowledge about. And these include protein inclusions, such as alpha-synuclein and tau. And I'm going to say more about that just a minute here. So when I look at a patient who has this constellation of symptoms that we call Parkinsonism, I look at them in this sort of general theme. So is it Parkinson's disease? Are there secondary causes potentially that might cause something that mimics Parkinson's symptoms like strokes, or we call vascular disease, or drugs, or even sort of a lot of fluid on the brain we call hydrocephalus? Or is it a genetic or hereditary disorder that might have features of Parkinson's like Huntington's or even Alzheimer's, okay? But really what we're going to focus on are these atypical Parkinson's disorders, which are primary Parkinson's disorders that have features that mimic Parkinson's disease. So these are the cousins of Parkinson's disease that we discussed today, like progressive supranuclear palsy, multiple system atrophy, dementia Lewy bodies, and corticobasal syndrome. Now, I am alluding to that we can sort of lump these disorders together also based on what we see in the brain neuropathologically. So we talk about synuclein as one protein that we see abnormal in Parkinson's disease, Lewy body disorders. We talk about tau pathology being found commonly among tau disorders like PSP, corticobasal syndrome, but also Alzheimer's disease, and I'll mention that. There are other proteins that we note and we see in the brain pathologically, amyloid, most commonly associated with Alzheimer's disease. And a relatively new player that we're seeing is called TDP43. It's another protein that's abnormally deposited in brain in certain disorders, particularly frontotemporal dementia. So this is kind of the soup of disorders that I see and that I have to think about when I approach a patient. There's a lot of diseases here. How do we tell if is it Parkinson's disease or something else? Well, there are some red flags. For instance, we know that Parkinson's disease is a gradual progressive disease, but when the disease is more rapidly progressive, in other words, within the first few years, really, there's more severe symptoms, maybe more prominent speech or swallow issues, a lot of early gait problems, getting stuck, frozen, frequently following within the first few years, a different kind of tremor, maybe not a rest tremor. And then there's this response to levodopa being the gold standard for treatment in Parkinson's disorders. When it's not working or helping, that's often a red flag to a neurologist or physician like myself. There are also some plus features. Sometimes there are eye movement problems that aren't typical in Parkinson's disease. A lot of problems with blood pressure, we call autonomic disorders, early cognitive, like dementia early on. Usually we see cognitive or dementia problems late in Parkinson's disease, not in the first few years. Psychiatric features or behavioral features. And then some other things like cortical features, we call like apraxias, fast jerking movements like bicycles. These can be clues to this is not just typical Parkinson's disease. So, you hear hoofbeats, you kind of think horses first. We're really talking about the zebras here, but sometimes there are those rare unicorns of atypical diseases. We're going to focus mostly on these zebras. And today, what I want to talk to you mostly about is the tau disorders or tau pathology and Parkinson's disorders. I'm going to focus mainly on PSP and corticobasal syndrome. Before I do that, let's talk a little bit about tau and its role in disease. So, first I want to say tau is a normal protein in brain. Okay, it binds and stabilizes microtubules. Microtubules are a structural protein in neurons. These are nerve cells that have really long axons that connect to other parts of the brain to communicate with them. So it's a stabilizing protein. Okay. However, when binding is disrupted, because the protein gets hyperphosphorylated, so phosphate is basically a molecule that attaches to the protein, it disrupts that. So, and what happens really is that with disrupted binding, you get disruption of those microtubules as well. Turns out then tau actually kind of segregates from microtubules, and it can form aggregates, shown here on the bottom here. I hope you can see my arrow pointing here. Those aggregates can form what are called neurofibrillary tangles or inclusions within cells. So there's a picture of one here on the right side of the slide. And of course, there are resulting things that happen when this occurs. So it makes the cell ill, and it also can cause peripheral or associated inflammation, and it leads to cell death or toxicity in the brain. Okay, so this is common to many diseases, and I want to talk about sort of this spectrum of both we call frontotemporal disorders that have different pathologies. This is a really nice slide from a paper from Nature Review Neurology. It kind of shows you that spectrum of diseases. I know there's a lot of acronyms on here, but the first thing I want to point out is there are these pathologies that I spoke about, TDP43, and then on the right here, tau. And I'm going to have you focus on this right side of the slide, really. So FTD stands for frontotemporal disorders or frontotemporal dementia. On the right side, on the far end of the spectrum, are those disorders that have tau pathology and actually Parkinsonism as a feature. These are more pure tauopathies, and particularly we call these 4R tauopathies, and those include corticobasal degeneration and progressive supranuclear palsy. So what are these diseases? So let me talk first about the most common form, progressive supranuclear palsy. So this is probably the most common form of atypical Parkinsonism. I show you the prevalence and incidence, about 6 in 100,000. That's still hardly what we see in Parkinson's disease, okay? We're talking about maybe 30, and if you're really conservative, it's probably misdiagnosed or underdiagnosed, probably 40,000 patients here in the United States who suffer from this disease. Onset is typically in the 60s, so close to what we see in Parkinson's disease, which is 65 years old for late onset Parkinson's. The key here I want pointing out here is the duration of symptoms. Remember I said atypical disorders are more rapidly progressive. Average duration of disease is about 6 to 10 years, and that's pretty scary. So let me talk to you about some of the hallmarks and what to look at. And these are actually some of those red flags. So the hallmark features are early postural issues, falling for no apparent reason, usually backwards, eye movement problems, gaze problems. We call this a supranuclear gaze problem. I'm going to talk more about this. Bulbar symptoms are those early speech and swallowing issues that happen here. So let me focus first on one of the key features, those falls. So look on the right here, a graph of falls and when they occur. So on the bottom of this graph, you see Parkinson's disease patients don't typically, on average, develop falls till about 5 years into disease. Comparatively, PSP patients develop falls within the first 1 to 2 years, and even at least the first 3 years. And you can see some other atypical disorders called multiple system atrophy or MSA and Lewy body dementia as well have earlier falls. But PSP really stands out as having these early postural balance problems too. There are a lot of other features though. Because they have so much stiffness and rigidity, their face and their eyes are kind of stuck. Their face tends to have this surprised look on them. Slowed movement, very common in Parkinson's disease, because they can't look up or down often. They can't see what's in front of them, or just looking as they're walking down steps, they may trip, or if they're eating, they have sloppy eating habits because they can't see their food very well. There are a lot of other features, of course. This is not just a movement disease. There are mood problems. They've ranged the gamut from apathy to irritability and even depression. Mood can become very labile, so if patients can cry or laugh uncontrollably. We call that pseudobulbar affect or PBA, something you may have heard on TV. And then even a frontal dementia. So this is a frontotemporal disorder or dementia disorder, okay? So I want to talk about the other key feature, that is the eye movements, because they're really particular in this disease. So there are a lot of eye problems in PSP. So impaired saccades are looking from one direction to another direction, okay? So looking up and down in particular are the most common problems in this disease. So up gaze limitation occurs as aging. It's really slowed down gaze that's a problem, and being shown here on the right in this little video here, okay? Patients have trouble fixating, and often their eyes dart back and forth. And because they have this stare and sometimes difficulty opening or even closing their eyes, blinking reduces. Patients' eyes often get dry. There's a lot of visual complaints, double vision, difficulty reading. You can imagine reading, you have to follow a line, and going up and down becomes really difficult if you can't look to a certain direction. So a lot of different issues that go on here. So I do want to mention that PSP now, as we recognize it, is not just one disease. There's a lot of heterogeneity, and we've learned this based on pathology and looking backwards as to who presented with what and what kind of pathology we saw. So the classic disease is what we call Richardson syndrome. This was described over 60 years ago now. There are some variants that look very much like Parkinson's. So they start out like Parkinson's disease, and then within several years, they become more like PSP because they have more gait and eye movement problems. There are some patients who have a primary gait problem. There's an overlap with corticobasal, which I'm going to talk about in just a minute. And there are other variants that they show here. The key really here is clinical progression. That's fairly rapid in these patients, okay? So there may be a pre-symptomatic phase where people are either getting diagnosed or misdiagnosed early on. It takes a while to become aware of what is this PSP, and then progression to either a variant, what we call typical Richardson syndrome in patients. So pathologically, again, this is a tau disease, and what we see is pathologic tau deposits, both in neurons and supporting cells. So here is kind of a really ugly inflammatory cell in the brain. And then we see the resultant of this, which is degeneration of specific parts of the brain, and particularly the brain stem. There is cortical involvement shown here, but multiple areas of the brain shown here get degenerated. Brainstem degeneration is particularly key in this disease, and we can actually look at brain scans, including MRIs, to get a sense, is this a progressive supranuclear palsy? This is an image of what we call the midbrain and the pons. This is basically the brainstem from a side view. And you can kind of see here, this is the brainstem of a Parkinson's disease patient versus a PSP patient. This part, the top of the brainstem or the midbrain, looks really tiny compared to the rest of the brainstem, and it kind of gives you this beaked or hummingbird-like picture. So people have actually called this the hummingbird sign in PSP. So in PSP, imaging is probably the best biomarker for us to use to help us with diagnosis. Unfortunately, blood tests or spinal fluid really isn't all that helpful. So we really rely on those imaging tests in many of our patients. So I do want to talk about the other disease that is a tau and Parkinson's disorder that's called cortical basal syndrome. So this is, again, a very rare syndrome, and actually is about 10 times less common than PSP. The key here really is the involvement of both the cortex of the higher brain and deep inside the brain. So patients often have both motor symptoms or Parkinson's symptoms, but also cognitive and behavioral symptoms as well, okay? Onset is similar, basically in the early 60s usually, and prognosis, unfortunately, poor, okay? Now, the thing about this disease is it's, classically we think about cortical basal, and there's this mix up in terms of cortical basal degeneration. Turns out cortical basal degeneration is a pathologic term and often mixed between the two of them, but it's only one type of presentation of cortical basal syndrome. So just like PSP, it's a heterogeneous disorder. And in fact, there are lots of different ways that cortical basal syndrome, now that we recognize it, can present itself. So there is overlap sometimes with PSP when people have a lot of gait problems and eye movement issues. Sometimes it presents as a primary speech and language issue. And other times it presents with significant cognitive impairment. And there are a lot of different pathologies. So most of the pathology is a tau pathology, but as you can see over here, only about 40% of the time is there classic cortical basal degeneration pathology. The rest of the time we see varied pathologies, including PSP, frontotemporal type pathology, and even Alzheimer's-like pathology in some cases. So a very varied disease, very difficult to diagnose. So I'm going to mention the classic presentation of this disease. So the most common way this presents is with asymmetric limb dysfunction or clumsiness. Think about this really. Parkinson's disease patients present with like a tremor or stiffness, but they rarely come to our clinic and say, my hand doesn't work, or my leg doesn't work, or doesn't do what I want it to do. That's an unusual complaint. So in classic cortical basal syndrome, motor symptoms tend to be markedly asymmetric. So one side of the body tends to be more affected than the other, to a greater degree than we see in Parkinson's disease. There can be a lot of rigidity. There can be an odd tremor. It's often more coarse rather than resting. There can be abnormal posturing, which we call dystonia. There's a lot of speech language stuff that goes on. And there's even eye gaze problems like we see in PSP. It's sister tau disorder. And then occasionally we also see problems with balance. The other part of the disease, the cortical part, are features such as language, okay? Problems doing programmed behaviors. Things are learned behaviors, okay? Using your hand, walking. These are behaviors you learned from being a child, and your brain programmed them over time. Even speech is a learned behavior. And in this disease, when the cortex or the higher part of your brain gets affected, you have trouble actually performing these tasks, okay? Alien limb is actually a weird phenomenon where a limb does something that you don't expect it to do, and you say it's kind of out of control. Sometimes it's a limb kind of raising or doing something like crossing over to your other limb and interfering with behaviors. There also can be sensory changes as well as a focal dementia, okay? So interesting disorder with both motor and cortical features. Again, this is a tau disease, but I'll emphasize really that only about 40% of patients actually have classic cortical basal degeneration pathology shown here on the right. You can see these plaques. These are all tau stains. Everything here in brown is a tau pathology. So plaques and astrocytes, these odd inclusions with neurons, and even these thread-like things that we see throughout the brain. These are all characteristic features of cortical basal degeneration, but not always seen. So this is something you can only see at brain pathology. And of course, we can't pull people's brains out to look at them. What we can do, though, is we can do imaging. And sometimes imaging, again, like with PSP, can be helpful. And we can actually see the involvement in the higher brain or cortex. So this on the right is an MRI brain picture. And I'm going to show you the brain tissue here is this gray part. And the black is actually fluid. And what you can see here in the back portion here, this is actually the frontal cortex. You can see that the folds here are very prominent, easy to see. This represents shrinkage or atrophy. And you might be able to tell that this right side of the brain versus the left side of the brain looks differentially affected. Okay, and that might relate to the symptoms that you see in patients or the asymmetry in the symptoms that we see. Okay, so giving you a lot of information about the different disorders. I do want to take us a few minutes to talk about treatment. It is complicated. So I want to talk briefly about the Parkinson's symptoms. So, one thing just to mention really is because these diseases have more prominent brain pathology, treatment is much more difficult, and often higher doses of medications are necessary. Of course, that goes along with side effects too, and they may not be lasting benefits. Nevertheless, treatment should always be tried in patients. So they have similar pathology to Parkinson's, and so we use the classic drugs like levodopa, carbidopa, levodopa. So I list that shown here. There are other drugs we call dopamine agonists like ropinirole or pramipexole. These in PSP and cortical basal syndrome don't often really provide that much benefit and cause other side effects that are not desired. So abnormal posturing we call dystonia. Levodopa doesn't really often help with that. So muscle relaxants can be tried. And then there's another thing that we often try in our clinic, which is Botox or botulinum toxin therapy, which can be injected in specific muscles and essentially relaxes those muscles so that you can move more freely. It also can treat pain, especially if those muscle spasms are uncomfortable. There are drugs that can treat the jerking movements, which we call myoclonics or the lightning-like jerks. There are also medications that can be used to target dementia. However, I will mention that those dementia drugs often are not as effective in these disorders, unfortunately, like they are in Alzheimer's disease or something called Lewy body dementia. There's few studies. So you can imagine these are rare diseases compared to Parkinson's disease, and getting enough patients to do adequate studies is often difficult. I do want to mention mood issues. Treatment with antidepressants are really helpful in patients, and one should try one for a few months, and if it doesn't work, do talk to your physician and try a different one. This we call labile or pseudobulbar affect can be treated with a drug called Nuedexta. I list the generic here. It's actually a cough medicine with quinidine. This can be a very effective drug, but also has some side effects, and it's kind of expensive. It can be very useful in patients who are laughing and crying to the extent that it's very disturbing and uncomfortable, both for the patient and family members. So I mentioned treatments, but I also want to stress that that's only half the battle in patients. It really takes a village. We at the University of Florida, we like to use multidisciplinary care and get our allied caregivers involved, and that involves our physical therapists, our occupational therapists, our speech pathologists, nurses, and social services or social workers, and even dietitians involved in care. This is a huge team, and you need it. This is a highly progressive disease, both of these. So you could help patients with their mobility, maintain their independence, their daily living, and improve their quality of life. It's a devastating disease, but why live and suffer when you can actually get some assistance? There are treatments, okay, and they're not just medications. So I want to stress this as well. I also want to mention just briefly palliative care, okay? This is not something just for these diseases. I realize they are very progressive disorders, but I want to mention it. That's something that physicians should discuss with patients. It's really more of a focus on quality and comfort and treating pain and suffering and well-being. What it isn't really is it's not about giving up on a patient. physicians should be involved. It's not about quitting care or even stopping all medications or losing your physician. So this can be very helpful. Having early discussions about end-of-life and advanced directives can be really important in these disorders to make decisions early on. So lastly, I just want to talk about some frontiers. I did mention imaging, but I do want to stress again, unfortunately, there's really no blood test or fluid test that we have that reliably can detect these diseases. So we rely heavily on imaging. There is one image that is FDA approved called the DAT scan. This is actually a SPECT, or a cousin of a PET scan, and it's a functional scan, and it allows us to look at the integrity of the dopamine cells in our brain. So this is a normal patient, and it kind of lights up we call the basal ganglia. It's a deep portion of the brain, but you can see on the right, these are Parkinson's patients. So this can be helpful to show that there is a dopamine deficit. The key thing here is it doesn't help us distinguish between Parkinson's and these atypical diseases, but it can be used when there is a question. If a patient's not responding to treatment, or if you're wondering, is this even a Parkinson disorder or an atypical disorder, this can be useful, okay? I can't really give this talk without kind of telling you about the research that's ongoing, because this is really the hope. These are devastating diseases. The last 10 years have been the most exciting in my life to see that these trials have come out, and that pharmaceutical companies are actively working on targeting tau and creating not just symptomatic therapies, but disease-modifying therapies. So there are lots of different ones, from just energetics, CoQ10, that have been tried. The bad news, so far, a lot of them have failed or had little benefit. But the good news is that a lot of people are interested, and the numbers of people interested are increasing. So there are a lot of trials out there that are ongoing. So for focused on disease modification, and getting in them is really important. I do want to mention, in addition to doing a drug study, there are also studies that are looking and understanding the disease better and looking for more markers that could help us diagnose disease earlier. One of those is this all FTD, or ARTFul, which is a longitudinal bank. Okay, so both looking at disease and looking at blood tissue, brain imaging as biomarkers of disease to study. And all the data basically is put together and made available to researchers around the country and around the world to study these diseases. So something, if you can participate, you should. There's a nearby center likely close to you, or we can get you close to them. So lastly, okay, not everything that looks like Parkinson's is Parkinson's. The frontal temporal disorders are a spectrum, and they do include PSP and cortical basal syndrome, but many other diseases. So there's more than just tau pathology in some of these diseases, and often sometimes they're together. The symptoms really overlap. You need a team approach, and of course, there are emerging therapies. So I'm going to finish there, and I'm going to hand this over to Janet Edmunson to give you a different perspective from a patient view of these diseases.
Okay. All right. Hi. Thank you, everybody. Let me get my screen up. Thank you, Dr. McFarland. That was fabulous. So we're going to talk about, I was asked to talk about caregiver concerns, like what's it like to be a caregiver when you're dealing with these diseases. So my husband, Charles, my late husband, Charles, had cortical basal degeneration that we found out from the autopsy. They thought possibly PSP, but it took really 3 years to get that diagnosis, which I think many of you can relate to. Taken a long time to kind of figure it out. They first diagnosed him as PSP, then as the symptoms progressed, it started looking more like CBD. I wanted to share with you some of the symptoms that I noticed with Charles that you may have. And again, everybody's different, but he early on had balance issues. He stumbled going up and down the stairs, fine motor movements, struggled tying a tie, buttoning buttons. I was getting him ready for work. The rigidity came later in the disease, and he became very, very stiff. The movement of the eyes, as Dr. McFarland said, he didn't have the downward gaze problem, but his eyes sort of were syncopated. And and he couldn't focus, and he had double vision as the time went on. Speech developed to be a problem about 4 years into this. And by the way, Charles's first symptom was in 1995. He died in 2000. So it was a 5-year progression for him. So the whole last year, he could not talk. And swallowing became an issue, but not as bad as other people in the support groups that I lead. But we were thickening his juices and his drinks. He did have apraxia, which Dr. McFarland said is where you can't make your body do what you want it to do. And that's going to be important when I tell you some of our other challenges. And he did have alien limb. His arm would just rise up and he wouldn't know it was there. And I remember at the doctor's office, looking at his foot and saying to the doctor, I see my foot, I know it's my foot, but it doesn't feel attached to my body. And then on the cognitive side, word finding came very early on, his thinking slowed, and he struggled with math. This is a guy that had 2 master's degrees, valedictorian of his high school class, coursework and all his coursework done in a PhD. And he couldn't do about 2 to 3 years into the disease, he couldn't do 2 + 2 or 3 + 5. His judgment was affected because of the executive function part of the brain. And you could see that he wasn't able always to make some good decisions. He had some inappropriate behaviors I'll talk about later. Depression was something he struggled with most of the time through this disease. Nothing seemed to help. He tried all the different medications, but we kept trying and hoping. And sleep issues, we didn't get solved until like the last year when he finally went on a drug called Seroquel, which really helped with some of the behavioral issues he was having. And then obsessions, I think, might have been caused by him being on the Cinemet, the levodopa, carbidopa for so long that he got obsessed with the Beatles. So we're playing Beatles songs all the time. It could have been worse. So we're happy for that. I'm going to take you through some pictures that show the progression of Charles's disease. This was 1996. Remember, his symptoms started, it was May of 1995. So we're probably a year into it. We're at the Olympics in Atlanta. And the main thing I noticed then was really stumbling on stairs. Charles was jogging at the time when this disease hit, and he was committed. He wanted to jog every single day. It was a commitment he made to himself. We did everything we could to keep him going. So after a while, after he fell sometimes, we found that I had to run with him, and I would grab other people whenever I could. You can see here his eyes and how his eyes were not focused on what was happening at hand. They were somewhere off. Here you can see me feeding him. Now, he really didn't want me to feed him for a long time, but at some point, it just became necessary. It was very hard, very early on for him to get his food to his mouth, and everything was a mess. Here you can notice sort of posturally, he is tilted back, and you can also start to see his hands starting to get a little bit of contractures, which you can see a little bit more here with his right arm, right hand being tight as a fist. And this is November before he died in May. And you can see here so many different things about him. I mean, he's really basically shut down in so many ways. And this was New Year's Eve, 2000, before the May that he died. And that's with my mother. And you can see again the contractures and the facial expression. So as we get started here, we want to know what issues you struggle with. So I'm hoping that someone can put the poll up. And I don't know if I need to stop sharing to get that. Okay, the poll is up. Could you guys answer? Select as many of these as you find are a problem with you. And then later, if you can put it in your chat box, things that I missed. So while you're doing that, I'm going to come back to these answers in a minute because in light of our time. I'm going to continue on, then I'm going to stop and we'll see how the poll came out. So I want to talk about I was asked to talk about what were some of our most difficult issues. And I would say for me as a care partner were the transitions. When Charles's disease got to the point where he needed to get to a different level of help. So the first was driving. I knew he was needing not to drive because he was getting bumps and dings on the car. And he didn't realize it till he actually pulled into a parking lot. There was a big green van that he didn't even see and scratched that car and his. And so we made that decision, but that was a tough fight. He had incontinence early on, and just getting him to wear the Depends pads was a fight. He didn't want anyone to help him with walking when he needed that extra assistance. So that was a little bit of a struggle until he finally let on for that. Using the wheelchair, I had the wheelchair brought in. Charles was very nice to the medical supply, but let me tell you, once that guy walked out the door, he yelled at me, said, "I don't need this. I am not an invalid. I am not handicapped." But our world was shrinking because he could only take slow, small steps. Finally convinced him when we wanted to go to the mall, let me try the wheelchair. We did it. We could get to so many places, and then we're over that hump. And then when he needed an aid, he resisted and resisted. But once we finally got one for him, it was 2 weeks in where he just loved this person. So my point here for care partners is that it's very difficult to get through some of these things, but if you keep going and work with your loved one, you'll get there, and then things settle down. And for those of you dealing with the disease, just know that your care partner is trying to do the best for you, and be willing to try some of these options. The other thing that was hard for us is Charles losing his speech, because he had apraxia. So if you can just think, he can't talk, so that we could understand him anyway, and he can't do with apraxia. He can't do one finger for yes, two fingers for no, because he couldn't do anything on volition. He couldn't blink one for yes or twice for no. So we just had to zoom into his eyes, try to figure it out, and just guess and hope for the best. He could grunt and be really mad if we got it wrong. So that would be some way that we would know. Changes in behavior. These can be all kinds of things. With Charles, there was a time where he just started yelling at 3 o'clock in the afternoon, just started yelling. That happened for a while, and that's where the Seroquel really helped us. But the apathy too, you can't see it. You can see here this very engaging face. This was way before he had the disease, when he was younger. But as you saw in those pictures, just how he got very apathetic looking. He couldn't express himself. And certainly when he couldn't talk, he lost that as well. And then the other thing, I had a hard time addressing the advanced directives like the living will and the healthcare proxy. Charles was young. He was 45 with his first symptom. And he was right in the middle of his career. So as we're figuring this disease out and it was progressing so quickly, it was really hard for me to bring up the fact that we needed to sign a healthcare proxy. You know what happens when you become really disabled, because I felt he would feel like I thought he was dying. Even though I knew he was, I didn't want to push that. Unfortunately, we should have had that done. I encourage every single one of you, even the healthcare professionals, all of us, do our advanced directives tomorrow. But the way I got it done was when Charles's brother, he had 2 brothers, they didn't live near us, but when one came to visit, it felt more safe for me to have the brother work with me and work with Charles to come up with and sign these directives. So we finally did get them done. But I wanted to close my time up with this concept, but I do want to get back to the poll, and we'll do that in a minute. But I wanted to close my session up on an up note, in that even in the midst of this very difficult, challenging disease, there are gifts. There are positives if you look for them. I think the biggest positive is just knowing that Charles and I were getting closer as we were going through this struggle together. You know, it takes a struggle for sometimes to get to that level of relationship. One of the gifts was, these are his 2 brothers. They weren't close. They were close as kids. They weren't close after Charles. I was Charles's second wife after Charles was divorced from his first wife. Their relationship split, but this disease brought them back. It was great to see the relationship that they had at this point. And a gift that I am so thankful for is the fact that I got to know Patty and Rhonda. Patty's husband had PSP. Rhonda's mother had PSP, and I ran a support group that they attended, and we became fast friends. And Charles died in 2000, and we've been friends ever since, and we get together. In fact, we just had a Zoom birthday thing last night. So it's something I very much cherish. Would I rather have Charles back? Sure, but that wasn't the choice I had. But at least this gave me the gift of Patty, and Rhonda. So I'm ready to close, but I'd like to go ahead and see if we can get the results of the poll, and then we can take your questions.
Janet, I put the results of the poll, the top 3, inside the chat function if you want to take a peek so you can see.
Oh, I see that. Thank you, Esther. So you guys said loss of executive function, and I did address that executive function, and it is hard when your loved one, oh, another one in regard to executive function is that they are impulsivity. So they think they can still walk. They can't. They think they can still do X. They can't. And that's very frustrating for us as care partners. Change in behavior. Yeah, these are the hardest ones, aren't they? And lack of communication. You know, I felt like I lost my best friend. And I came home one day from work where things just fell apart at work. And usually I'd come home and Charles would be my mentor and help me through that. I got home, he was in his hospital bed. He looked up at me, couldn't say a thing. And I realized, you know, I've lost him in regard to that. So that's a very sad part and a reckoning that you have to have. So that's what I would say about the top 3. Thank you. Do we want to take questions now?
We do. If Dr. McFarland can come back on screen too. Janet, I just want to thank you for sharing your personal story and your personal journey. You know, it really helps as a healthcare professional and somebody working for the association, hearing your story really helps shape what we know the community needs. And so just thank you for your openness and honesty in sharing that.
You're welcome.
Yeah, that was fantastic.
Yeah. One of the questions that came up was, and this is probably for you, Dr. McFarland, but in CBD, do we typically see the apraxia that occurs? I know it occurs on one side. Is it typically on the dominant side or on the non-dominant side, or is that not characteristic?
So it can occur on either side, really. It's not really well understood why one versus the other. So I see left or right, dominant, non-dominant, it just depends. I think it's just unfortunate if it does occur on the dominant side, and I see a lot of patients will gravitate toward their using their non-dominant side to do a lot of their activities, you know, just to compensate. But eventually, I will say, folks, that it does spread and eventually affects both sides of the body. There will be a predominance on one, but it does spread to both sides.
Thank you. Another question that came up, and we only have 2 minutes left, so we'll try to answer this so that we can move into the next session. But if somebody's loved one is displaying these symptoms, where do you recommend that they go for diagnosis? Who's the best person for them to reach out to?
Yeah, you know, what I would tell folks, just my recommendation really is that you do need to see a specialist. So a general neurologist or is great. If they are knowledgeable enough, that's wonderful. But you need that team, and to see what's called a movement disorder specialist is really critical, and to find a center where there is that multidisciplinary, that team of folks, that allied healthcare. A physician alone is not enough. You know, we have built something here at the University of Florida, but I know there are many other centers around the country. And I would suggest to you, there are organizations, AFTD, you know, yours is great. The Cure PSP here in the United States does list a bunch of centers on their website, centers of excellence or centers of, you know, of the Cure. So there are ways to find those centers, and feel free to reach out to us and we can help point you out. I realize that it often takes, it's driving and getting there. The one good thing of the pandemic, I have to say, has really been the acceptance of telemedicine, and our ability actually to reach out to patients via video, just like we're doing right now. It's not the most ideal or favorite, but it's better than not being able to get to our patients. So
thank you. We have 1 minute left, so I just have one question for you, Janet. And that's, if you were to find one thing that really made your journey with Charles, that gave you the most support and helped you get along the most, what would you name?
The support group. I learned a lot from the neurologist, and I totally agree with Dr. McFarland on getting to a movement disorder specialist. We went to 5. We were in the Boston area. We went to every hospital. Charles wanted to know what he had. But I would say a support group. But then I would say next to that would be a good network of friends who can support you as well.
Great. Well, thank you both so much for joining us today and bringing your insight and your story for our audience. This session will end up being broadcast on our website after the conference. And so I'm so glad that we were able to offer this today. So have a great day, and we will see all of you in the next session with Dr. Adam Staffaroni in just a few moments.
Great. Thank you all.